Okay, welcome to tonight's RACGP webinar on cancer and COVID-19 in relation to delayed cancer diagnosis and the impact on primary care. My name is John Emery. I'm Professor of Primary Care Cancer Research at the University of Melbourne and the Research and Education Primary Care Lead at the Victorian Comprehensive Cancer Centre. First of all, I would like to acknowledge the traditional owners of the lands from where each of us is joining this webinar today, and we pay our respects to elders past, present and emerging. So I hope most of you are familiar with the webinar settings and have used this approach, but as you can see at the bottom, there are audio settings that will allow you to manage that. And if you can't see your control panel, hover your cursor over the bottom of the share presence screen and it will appear so that you can adjust your audio settings. We will be inviting you to add questions as the presentations are delivered through the Q&A function and typing them in. But we'll be taking questions at the end of the presentations as part of the panel discussion. As you can see at the bottom, there's the Q&A function for you that allows you to enter those questions at any point during the webinar. So this evening we have 4 speakers. Professor Sue Evans, who is the Director of the Victorian Cancer Registry, Dr. Ines Rio, who is a GP in North Richmond and Chair of the North West Melbourne PHN, and Miss Jane Fox, who is the Director of Breast Services at Monash Health. Tonight's event is partnered with the Victorian COVID-19 Cancer Network. This is an organisation that has been brought together as part of the response to COVID within Victoria. It's a joint initiative of the Victorian Comprehensive Cancer Centre and Monash Partners Comprehensive Cancer Consortium, and it aims to provide support and advice to clinicians and healthcare services treating patients with cancer during the COVID-19 pandemic. Tonight we're going to be focusing on the impact of the restrictions that we have all experienced during the COVID pandemic and its impact on new cancer diagnosis. We'll be hearing data from the Victorian Cancer Registry, but also national data as well, and reflecting on the primary care sector's response going forward. And these are the specific learning objectives for this evening. As I said, this is supported by the Victorian COVID Cancer Network and as discussed. So before we begin, we wanted to get a sense of your perspectives and experience of the impact of COVID on cancer. So we have a number of polls. And so the first relates to, have you noticed a reduction in patients presenting with symptoms of cancer? Okay, so obviously a sort of slightly mixed response, but potentially certainly some perception of a reduction and others unsure exactly. It's difficult to tell, of course, at an individual level exactly what's happening at a higher population level. If we go on to the next poll. So have you noticed a reduction in patients presenting for routine cancer screening, particularly thinking about cervical cancer screening, but also discussions around the national bowel and breast cancer screening programs? And again, sort of similar perceptions that there has been a reduction and slightly greater certainty, I would suggest, around misperceptions of impact on cancer screening. I think we have one more question. So, have you noticed patients are more reluctant to have tests or diagnostic tests for cancer after you have seen them? Okay, so I think again, this is a slightly harder question to answer with certainty, but we will be presenting some data both at a Victorian and a national level as to what has appears to have been occurring and discussing some of the potential reasons for that. So I'd like now to hand over to Professor Sue Evans to talk about some of the more precise data from within Victoria from the Victorian Cancer Registry. Welcome, Sue.
Thanks, John. Thanks very much. The data that I'm going to be presenting today, I think will give a bit of a conversation starter to what we'll kind of be pursuing throughout the rest of the hour. I would like to start by acknowledging the team behind me that has been able to pull this data together for me to present to you today. And I'd also like to acknowledge the 18 laboratories that have provided the data that I'm going to be presenting as well. As John mentioned, this data are presented to the COVID task force, and we've had clinical advice from Grant MacArthur in putting this together today. Thank you. So just by way of background and how we get the data to the Victorian Cancer Registry, cancer notification is mandated under the Improving Cancer Outcome Act. So all pathology providers and hospitals are required to report any cancer diagnosis to the Cancer Registry. In 2015, we put in a system called EPATH. It sat on the back of laboratory information systems, and it automatically pulled cancer notifications from the laboratory system and sent it through to the Victorian Cancer Registry. With the implementation of EPATH, we saw a huge increase in the number of notifications, even though it had been mandated beforehand. The EPATH system certainly improved our ability to capture cancer pathology data. We get notifications through EPATH from about 94% of pathology, or 94% of pathology is submitted using the EPATH system in Victoria. When it was introduced in 2015, it went through some tweaking to improve the sensitivity to get it to 99%, and also to improve the specificity, that is to reduce a lot of the duplicates and the non-cancer related reports, which has meant that our system now is fabulous, but we can't unfortunately compare the number of notifications that we got last year to the ones that we have this year, because the system has been improved so much. So we've done some modelling, and that's what I'm going to be presenting to you in this presentation. So as I mentioned, the data is coming directly from the laboratory information system through to the Cancer Registry. It's important to note that when it gets to us and what I'm reporting through the first EPATH monitoring console results hasn't yet been seen by the clinical coders. It's not an indication of diagnosis, it's an indication of activity. So for example, one cancer diagnosis may have a number of pathology reports that sit behind it. In terms of follow-up care and some additional sort of more specific tests for the cancer diagnosis. So thank you. So what I'm presenting now is the data from when we started this process back in January, all the way through till the end of September. There's a couple of time points that we've put in the presentation. You can see that on the 29th or the 30th of March, we went into level 3 lockdown in Victoria, and we saw a pretty sharp decrease over the ensuing few weeks in cancer notifications coming through to the cancer registry. There seemed to be a little bit of a recovery, and we were coming out of lockdown when we were then put back into lockdown on the 8th of July. Didn't see any real impact, and even when we went into level 4 lockdown on the 2nd of August, whilst we were expecting to see it plummet again, it held its own really, and you can see that sort of shown in the bar charts that we haven't seen a drop off that we saw certainly back in March when the level 4 restrictions were imposed on the 2nd of August. So I'm now just going to run through the next part of the system that we use at the Cancer Registry, which enables us to give you a little bit more detail on the trends by the different tumour streams, by patient age groups. Still hasn't had the coding eye over it, but it does allow us to give more granular detail to the statistics. Thank you. There's a 5 to 6 week delay, so the data is not quite so new as the notification data that you saw, but I'm going to be presenting the data up till the end of August. So as I mentioned, we can't compare our notification data to the same time last year. So in order to provide an indication of the impact, taking into account seasonal trends, we overlaid the diagnoses data on top of the notification data. I'm very happy to share the methodology that we used to do this. I'm not going to labour that at the moment, but you can see on the right that each year for the last 5 years or 6 years that I've got reported there, 5 years, you know, there is definitely a seasonal trend. Over Christmas it picks up, 0 being January 1, drops off a bit towards Easter, and then obviously drops off at the end of the year as well. So we were able to use that notification data overlaid with the diagnosis information from previous years. With that information on cancer diagnoses, we were able to put some trend lines in, which you see in green, which relate or refer to the trend in cancer diagnoses that we would be expecting to see at this time of the year if it were any of the past few years. The dots that you can see represent our current data for this year. You'll see that there's some dots at the bottom of the screen that they are our weekend activity and public holiday activity, and the data at the top is our weekday activity. So we get about 300 to 400 notifications through each day. Thank you. This is just showing you the drop-off that we see graphically. There was a little bit of an increase in the baseline period, but by and large, the notifications have dropped off somewhat over this entire period. If you look across the x-axis, you've got the months, and those timelines that you see on this chart represent the different time points where the lockdowns were imposed in Victoria. Again, back in March, we had the early one. Towards August the 2nd, we've got the level 4 lockdown, just so that you've kind of got that in mind when you're looking at the following graphs that I'm going to present to you. Thank you. So if we compare now, if we look at the chart now, you can see the green, as I mentioned, is where we would expect the diagnoses to be. The red line is the trend line following the notification. So the gap between the red and the green is the reduction that we're seeing. For the period from April 1 until the 31st of August, we've seen an 11% decrease in notifications for what we would be expecting to receive in the cancer registry. And that has equated to about 4,600 fewer pathology notifications. Broadly speaking, that's about 1,950 fewer diagnoses of cancer that we're receiving in the cancer registry for that time period from April till the end of August. Some confidence intervals around that. So hopefully now you can sort of cast your eyes over that and be able to look at the different squiggly lines and make sense of them. You can see that the most significant decline in notifications that we're seeing in the cancer registry are for those who are aged in the 50 to 74-year-old age group and in the age group over 75. So in fact, we can see an 11.8% increase overall in that screening population aged 50 to 74. There doesn't seem to be so much recovery either happening in either of those age groups at the moment. I'm now going to go through some of the main tumour groups so that you can get a bit of a sense of how those numbers break down by the different tumours. It's quite different. You can see the melanoma on the far left. We would see normally we would see quite a large seasonal drop after summer, and you can see that in the green it has dropped away. We did see a further decline back in April, May in notifications. In fact, melanoma dropped. The greatest decline in melanoma was a 22% decline, which was registered on the 6th of May, but there has been some recovery happening in melanoma. The breast cancer, again, we saw the greatest decline there. On the 11th of May, we had a 28% decline in notifications, and that was really around the time that BreastScreen had closed and hadn't yet started to bring back patients on a reduced basis. The haematological services have been slightly impacted, but certainly not so much as either melanoma or breast. So if we look now at the prostate cancer diagnoses, you can see from the trend line, the red line, that it's continuing to decline. We haven't seen any recovery in notifications of prostate cancer coming to the registry. In fact, its lowest point was at the date of censor at the 31st of August. Overall, the biggest decline that we saw there was 31% that we're seeing at the end of August. Colorectal cancer hasn't really been so much impacted so much, and nor has lung cancer, which is probably not surprising because a lot would be symptomatic for lung cancer and going to emergency departments for care. When we look at bladder, head and neck, bladder and head and neck particularly, you do have to be mindful that the numbers of pathology notifications we're now getting to a reasonably low number. You can see the scatter plots much broader because of these low numbers. But it is worth noting that we did see quite a decline in head and neck cancer notifications, and that was at a time 41% in fact decline in early May. And anecdotally, when we were talking this through with the task group, they were suggesting that that might have been impacted by dental consults dropping off and dentists not seeing patients in the early stages of lockdown as well. So I'm now just going to give a run through on the notifications and the differences based on socioeconomic status. This is determined through the residential address of the patient. It includes about 100 houses within a geographic block as given a socioeconomic status. So socioeconomic status quintile 1 refers to the most disadvantaged group. We're working its way up to the 5th quintile, which is the most affluent. So looking at the trend lines there, you can see that as we move to the least disadvantaged, the more advantaged population, the drop-offs are noticed more. Again, we're now looking at the differences that we see according to regions. The decline in notifications have been most marked in major cities and in interregional, although interregional has certainly recovered more than we're seeing in the major cities. And again, the lowest point is at the point of censor at the end of August. So we haven't seen any recovery happening there. Not probably that we would be expecting to with level 4 lockdowns, but one would hope that we can see some recovery in the next few weeks when things are opened up a bit, and hopefully a rebound. You know, we would also like to see it go up the other way to recover from those patients not diagnosed back in March. So in conclusion, we have seen a decline in cancer notifications. Most notably, we're seeing them in those aged over 50 in inner Melbourne and in the highest socioeconomic group. Our modelling suggests that in the next few months we will, well, if it continues for the next month, we will have 2,000 fewer diagnoses of cancer than we would be expecting at this time of the year. So I'm going to we don't obviously know what impact that will have on stage migration for some cancers like prostate. Perhaps we won't see much impact, it's a chronic disease, but for others we might see stage migration. I'm going to now ask you to please complete this poll. Does the data reflect what you have seen in your practice? Okay, and I'm going to hand now back to John. Thanks, John.
Thank you, Sue. We'll just let the polling complete, but I think there is a sort of sense that this does at least fit with GPs' personal experiences of what has been occurring in their practice around patients presenting with symptoms of cancer and so on. Thank you. So I'm going to now move on to discuss some national data. So we've obviously heard Victorian data. It's worth commenting that the findings that Sue has just demonstrated are consistent with what's occurring internationally as well. And so this is a very clear phenomenon that has been occurring around many countries as an impact of COVID, this reduction in cancer diagnoses and concerns around delays in cancer diagnosis. This is the first national data that was reported last month from Cancer Australia that's been looking at MBS data on a number of markers of cancer diagnostic tests and comparing those rates of diagnostic testing with 2019 data. So the first is around skin excisions for melanoma. And again, in the period from May to June at a national level, there was a large 25% reduction in excisions for melanoma compared to 2019. Now, these data relating to breast imaging don't account for impacts on the breast screening program. This is just around diagnostic imaging ordered by doctors for presumably mainly for breast symptoms and the investigation of breast symptoms. And again, during the period of March to April, there was a 37% reduction in requests for imaging for suspected breast cancer. You can see a fairly rapid recovery at a national level though, which is encouraging. The consequence of that reduction in breast imaging is also seen in subsequent reduction in breast biopsies. So again, a 25% reduction in breast biopsies in the March to April period, but again with some evidence of a recovery by the end of June. Colonoscopies, an even larger impact. Not surprisingly, this is slightly delayed, and that probably reflects the referral pathways. So between May and June 2020, there were 36% fewer colonoscopies conducted at a national level. So a very large effect on colonoscopies. So this is another poll question, and really in the context of a lot of debate around whether this is due to patients actually just not presenting to their GP with cancer symptoms. That has been what has been reported in the media as the main explanation. But are there other possible explanations for why this may be occurring? Thank you. So that's really interesting. So around about 42% think this is mainly to do with an issue of fewer patients presenting to their GP with symptoms and an impact on cancer screening. Interestingly, there's no sense that this is a referral issue, but that telehealth consultations may make it harder. I welcome people, if they have the opportunity, if they're what those others are, please put them in the Q&A, because I'm intrigued to understand what people think may else be going on to explain this. So this again is from MBS data and reflects the impact that COVID had on GP consultations. And going back to that poll where there was this perception of a reduction in patients presenting to their GP. In actual fact, total GP consultations increased during the period of COVID. So that although that has been discussed as a major impact, that we haven't actually witnessed this in the MBS data. And overall consulting did not fall, it actually increased. But the important thing to note is the change in patterns of consulting. So there was a very rapid adoption of telehealth with the new telehealth items in response to COVID. And so a third of those GP consultations that occurred between April and June were telephone consultations. Again, you'll see very limited uptake of telehealth video consultations. And again, that might be an interesting thing to discuss later, but a very large uptake of phone consultations. We've also seen the impact on specialist consultations. So in this case, there's been a reduction in specialist consultations, suggesting a reduction in referrals again, for specific professional attendances that in the Cancer Australia report that were thought to be relevant to the cancers considered in the data that I presented earlier. So 24% fewer specialist consultations in March to April. Again, you can see that specialists have also adopted telehealth consulting with a slightly higher pickup of video, but again, the majority of those, again, are occurring by telephone. So I think just to summarize what the national data show, which I think is contrary to what some of the perceptions have been. So we know that there has been between a quarter and a third reduction in cancer testing for melanoma, for breast cancer, and colorectal cancer. This is not reflected, though, in a reduction in overall GP consultations. So this isn't just simply a phenomenon of patients stopping going to attend their GP. There's been a big switch in the way consultations occur, with a third of those occurring by telephone and a quarter fewer specialist consultations. So there has been a dramatic reduction in referrals, which is part of the story. And I think we may now have another polling question before I hand over to Jane. So again, this relates to a question around access to specialist cancer care. Have you actually found it harder to obtain that specialist care when you needed it? Okay, so interesting. So about half are feeling that it actually hasn't become harder. And so again, that sort of reflects on that there has been this large reduction in referrals, but it's not necessarily because it's actually been harder to obtain that. Though I accept that there's a fair degree of uncertainty as well. So I'd like now to hand over to Jane Fox to present some of this from the perspective of a breast surgeon. So welcome, Jane.
Thank you, John. Good evening, everybody. I hope that sorry, I just need to click on something again. I hope that what we can do tonight, some of this is the work that's been done by the Breast Advisory Group of the COVID Cancer Task Force, which is a group which has got wide representation, including the chair of your breast interest group. And we've certainly had some robust discussion, but we can't provide all of the answers. I think that using breast cancer as an analogy for particularly the sort of big 5 cancers that we commonly see can be useful, but it's obviously not perfect. And so we know that this is a disease where there is really good community awareness of the common symptoms and enthusiasm about investigating things appropriately. We have a national screening program. We're faced with what is really a fairly non-heterogeneous disease with about 5 major subtypes. We have multiple effective treatment modalities, increasing use of initial systemic treatment, which I'll come back to later. It's actually rare that someone needs urgent surgery for breast cancer, and we have a shared challenge of long-term post-treatment surveillance. So just to share some data from the Australian Institute of Health and Welfare, they've actually looked at the amount of breast screening. And if we look at the Breast Screen Australia population screening program, there were 145,000 less screens in the first half of this year compared to 2018. And that's compared to 2018 because it's a 2-yearly screening program. That presents challenges of its own because to catch up 145,000 screens or more at a time of social distancing, potentially some staff limitations, is actually very challenging. But it's really important that within that group, we don't forget about those women who've never been screened that are within the target age group. We need to be aware of the people that are at much higher risk of being diagnosed with an interval cancer between screening episodes. And that can certainly include people with significant past history or family history, and some of the women with high mammographic density. And that really brings us all to have to consider who might benefit from more frequent surveillance or the use of other modalities. And BreastScreen addresses some of the questions around frequent surveillance, but is at this stage unable to address the questions around density or the use of other modalities. So just to put that in another graph, you can actually see how dramatic that fall in screening mammograms has been. And you can also see that up until July, there had been certainly good recovery, but it's really plateaued off. And with the perspective of being in Melbourne, we know that a number of our screening sites have now got about 13-week waits to get appointments. So for some women, that 3-month delay is potentially quite significant. So I guess this is the sort of patient that we really don't want to meet. You can see a mediolateral oblique mammogram on the left of your screen with a very typical stellate lesion fairly centrally placed in the breast with typical malignant features. If you look a little bit more closely up towards the axilla, you can see some quite dense looking nodes. And the picture on the right is actually an ultrasound of the axilla, because this patient, who had never been screened and was fairly reluctant for various reasons to present for medical attention, in fact had noticed a lump in her axilla and retraction of the skin. And when we did some staging investigations on the middle frame, you can actually see that she has liver metastases, and she also had lung metastases. She's lucky she had a HER2 positive disease. And it may well be that she'll get a really excellent response to treatment for that. But these are really the people that we don't want to miss those cancers. So breast cancer biology is really quite diverse. So we see low-grade disease with a very low risk of metastatic spread and slow progression. I saw a lady today who's had a mucinous cancer. She was first diagnosed in 2008. For various reasons, she's had a number of local recurrences, largely due to the type of treatment that's been acceptable to her, but she has no evidence of metastatic disease. On the other hand, you see patients like the one that we've just shown with high-grade cancer and metastatic disease when she has just a small primary cancer in the breast. So we really need to have an understanding of the risks of overdiagnosis and overtreatment without undertreating anyone, and that's going to become particularly relevant. A couple of weeks ago when we were making these slides, I thought we were really all talking about when the patients who had not yet been diagnosed were actually going to start coming in. And in the last week or so, we've actually seen large numbers of patients presenting, some of whom have delayed presenting with symptoms and almost certainly going to require more treatment than they otherwise would have. We still don't know about the stage shift, but we are expecting patients who will need more intensive treatment. So just a comment about neoadjuvant therapies, because I think they're really discussed a lot by people treating breast cancer, but perhaps not so familiar in general practice because you don't have the same numbers of patients. Once this was used exclusively in an operable disease to try and bring disease under control, but its use now is much more related to tumour size and biology, particularly for triple negative breast cancers or HER2 positive breast cancers. And it really provides us with information about biological response and prognosis. And now patients can access new targeted treatments, particularly if they don't actually get a very good response. Our main uses are that we downstage the tumours and we can therefore reduce the extent of surgery and possibly radiation therapy. And that may become quite important when we're looking at how we triage treatment over the next 6 to 12 months. These are usually chemotherapy and targeted therapies, but in your older patients in particular, you may see an increasing use of neoadjuvant endocrine therapies. So we think that there will be some constraints in managing increased numbers of breast cancer diagnosis. Around the hospitals, outpatient appointments are already at a premium, and a lot of public hospitals have used a lot of telehealth over the last 6 months. We know that the oncology workforce, particularly in terms of medical oncologists and oncology nurses, is quite limited across the country, and that's going to prove challenging when there's an increased amount of systemic therapy required. There is increasing competition for theatre access as people try to catch up, although the breast cancer surgery is all category 1 and it's all been done fairly normally. We actually are going to struggle with reconstructive surgery. In fact, the BCNA, the Breast Cancer Network of Australia, is already well aware of that problem. There's a marked increase in our need for allied health, particularly psychologists and rehabilitation services after cancer treatment. And there are already quite long waiting lists to see psychologists who specialise in this area. We think that surgical opinions, public clinics and hospital-based diagnostic imaging is broadly available, and that can really be for consultation and investigation, but it also suggests that it can be a really good support if you want advice about patients who are presenting, that we should all be available to have conversations about patients anyway. So really, to summarise, there are a number of opportunities and challenges, and some of these the Breast Advisory Group has been trying to address. So we're actually looking at stratified screening, which is really about ensuring that women at the most risk of having breast cancer, which is asymptomatic, actually are screened. That's partly a challenge for Breast Screen Australia, but it's actually quite a difficult thing to do. And it's very difficult to actually change the existing screening program. So I think it's really important for all of us who are talking to women to try and recognise those women who are at higher risk and not necessarily leave that to the screening program, but actually refer people for screening imaging. We know that there are potentially going to be people with serious economic challenges over the next, again, 6, 12 months, maybe longer. And again, knowing that there are publicly funded clinics and public screening available may be really important for those patients. We are looking at ways of identifying lower risk disease, and that's particularly around getting molecular profiling for estrogen receptor positive breast cancer and working out who can safely avoid having chemotherapy, which has huge benefits to the individual patient, but also has very significant economic benefits. We would really like to be able to de-escalate treatment for low risk disease, and there are quite a number of studies looking at reduced radiotherapy. We really need improved data collection around metastatic breast cancer. We don't even know how many women are out there with metastatic breast cancer, and the services that they need are really important. I think that a lot of people will be aware of shared care models in various areas of healthcare. And I think effective shared care for cancer patients between their specialist service and their GP service is challenging. We have disparate funding models, we have disparate IT platforms, and not necessarily very good communication strategies, and that really needs overcoming. We'd really like to see more use of patient-reported outcome measures in real time, which can improve patient-centred care and also get over some of the obstacles of telehealth. And I think the other thing that will become really important is that we actually collect outcomes data for this period. So I'd like to hand over to Ines, who's going to take you further into that.
Thank you very much, Jane. And thank you also for your speech, and also Sue and John's. And, you know, it really brings home the changes that we've actually undertaken as a healthcare system and as a society since the COVID pandemic. And there's no need to tell any GP that's listening or any health professional that's listening that we've made fundamental changes in the way we deliver care across general practice, but also across the sort of healthcare pathway and healthcare, public healthcare as well, and also the oncology sector. And it's required that balancing of risk of infection to patients, staff and ourselves against the benefits of the identification and treatment of cancer, along really with the consideration of keeping our healthcare system resources there and maintaining them in case we require them for a COVID response. And as you've seen from Sue, Jane and John, this has resulted in really problematic and unforeseen decrease in cancer identification. So as John said, that's actually been found around the world, but it's resulted in an estimated decrease of 2,000 diagnoses of cancer over 6 months just in Victoria, which is largely aligned to sort of your experiences in the poll. And not surprisingly, that's actually been reflected in other care environments. So certainly, you know, there's been a decrease of something like 30% with cardiac emergencies as well. And that's likely to be a harbinger for a whole range of other healthcare conditions. So we need to think about this, I think, as a complex mixture of changes in behaviour and interaction of patients and providers, but also across healthcare systems. That's decreased access, identification and care. And unfortunately, as has been described, this will result in a tsunami essentially of cancer identification and care that's required later, and also a staged progression. But, you know, we are where we are. And in thinking on the way forward, we really need to think about the opportunities and the things that we've developed over this time period that we can bring forward and embed in a new sort of healthcare system model, and what we need that's enhanced and modified that will result, you know, we'll be able to respond to this tsunami of presentations in primary care and also in the hospital sector, but also be able to modulate our healthcare systems as Jane mentioned before, aspects such as shared care, etc., that we've dabbled with before and we know can be really successful, is actually grow those value propositions in healthcare. So this Road to Recovery and Learnings document's been developed by the Cancer Council and the Victorian COVID Task Force. It's accessible on the web and it speaks to that sort of systematised approach of what we need to think about moving forward at the systems level, the service level, at general practice, screening, and also hospital and specialist systems, at the doctor practitioner level, and also at the patient level. So, you know, the targeted strategies that they've looked at are those 12 targeted strategies. And I'll mainly speak to the ones that are relevant to general practice with my GP lens, which is 4 there. So the ability, obviously, to have MBS-funded telehealth consultation started on the 3rd of March and was a seismic shift in general practice, was a game changer for the broader healthcare sector. And there's obviously been lots of iterations, starting from it being only available to vulnerable patients and doctors, that seemed like quite a while ago, to all of it being a bulk billing requirement, to dropping the bulk billing requirement to the GP for non-GP specialists, but keeping it for GPs, and recently for dropping the bulk billing requirement for GPs as well as the bulk billing incentive. But it's also been extended to the 31st of March 2021. However, it is a still a temporary telehealth MBS item. And most GPs have offered it, and John spoke to that, and the vast majority have been done by telephone. John was speaking to the fact that overall 30% of consultations in Australia have actually been by telehealth, but much higher rates in Victoria, understandably, and very few by video. And the vast majority of GPs offering telehealth services, over 97%, also offer face-to-face services. So as we know as providers, telehealth has enabled, reduced exposure to COVID for healthcare providers, for staff and for patients. And that's particularly important for cancer patients in the context that many cancer patients are immunocompromised and many are older. It's also improved the likelihood that people would get care, especially in this locked down environment and fears of infection. It's improved access for those with access issues, physical access issues, geographical access issues and healthcare ones. And again, that's something really positive that we can move into the forward, into the future. And it's also enabled the multiple healthcare professionals to interact in the one consultation care plan. Again, a very positive issue that we can move forward, and it's been highly convenient for patients. So it has been, and it's been very much supported by patients, the healthcare peak bodies and GPs, and I think it will be a very hard egg to uncrack. So the question is, where to from here? It's been extended, as I said, to March 2021. I suspect suspect it will continue. Please don't hold me on that, but as I said, I think it will continue in some form, and certainly the Federal Health Minister has affirmed his support for it. But I do think we need to better understand the benefits and the risks and support that they're used in a clinically appropriate and safe way and in the context of an established clinical relationship, which is actually the item descriptor at the moment. And we also need to better support the uptake and use of video telehealth, as there's both sort of theoretical reasons and there's also some clinical evidence of improved satisfaction and assessment. But we need to better understand that. And we also need to actually think about it as a tool that specialist services can support GPs in their care of patients with cancer. So I think that it's such an essential tool that we've developed and adapted very quickly for our use, but we need to incorporate it so it sits within that usual GP patient-centred medical home model and is an enabler for multidisciplinary team to support access, continuity, comprehensive and coordinated care. So just briefly, some of the population cancer screening program aspects. As we heard from Sue, we've experienced fewer cancer referrals and notifications. And in Australia, some of the cancer hospitals also reported reduced referrals of new patients. And we saw that drop that Sue was talking about before. We saw the breast cancer screening program close between April and August this year, but very importantly, it's up and running now. And there's been a decrease in bowel cancer screening tests being returned. And you might all be aware of the recent media campaign to actually improve this. And there's been a decrease in both cervical screening, but also the follow-up of positive tests. So the resulting delay in diagnosing cancer is due to this disruption of screening programs, delayed GP visits, decreased opportunistic screening, and delayed access to diagnostic pathways. And so that model, as we've said before, will result in a surge in diagnosis in cancer as we move out of this phase and in patients presenting with potentially more advanced disease or staged progression. And this means an overload of the system, the need for more complex treatment and poorer outcomes. So, what do we need to think about moving forward? And I think that, as GPs and as general practitioners and within a healthcare system, we need to be alert to the fact that there's likely to be an increase in cancer burden and undiagnosed cancer amongst our patients. We need to consider how we might identify, target and encourage our patients to catch up on their screening, opportunistically and also in a targeted strategy, practice-wide strategy. We need to be able to analyse and monitor our own and our practice data and see how we're faring across the cervical screening, bowel cancer screening, breast cancer screening. And certainly the cervical screening is one of the 10 QPIP markers. So you should be able to get some help from your PHNs and they might be able to help you with the other screening markers as well, see how you're tracking. And also discuss with your colleagues and adopt a systematic practice at a professional approach to timely and evidence-based investigation, referral of symptoms and signs suggestive of cancer. And certainly the Melbourne Health Pathways that's offered by the PHNs as a desktop tool incorporates the optimal care pathways within that, and hopefully something that you find very useful and is certainly well taken up by GPs. There's also the opportunity within screening programs, as has been talked about, for them to review their target groups and access and message to underpin issues of equity and outcomes. And I think very importantly, between the screening programs and general practice, there's an opportunity for the screening programs to better communicate with GPs and in a way that's easy for us to capture that data to create reminders and recalls. Just briefly, virtual multidisciplinary meetings. Obviously, it's been picked up within oncology services so that many of those are actually virtual meetings now, and that's enabled more efficiency amongst the participants. However, I'm also hoping that it will enable greater participation by GPs and other community health professionals. As a GP, I've been to a few multidisciplinary team meetings for my patients, which I've found extraordinarily helpful in my ongoing care and which I hope I've added value to. But I'm rarely invited and I can go even more rarely as it's just so impractical. But I see this as a real opportunity to engage GPs and make better recommendations for patients that deliver a better, more individualised, comprehensive and coordinated care across healthcare settings. So just finally, you know, I've been involved in many, in the development of shared care models across cancer and non-cancer, and when they are well thought out and supported, they work brilliantly. Patients get the best of both worlds. They have the convenience and the comprehensive care provided by their GP, who continue to see them, provide their sort of whole person care, who actually see them for a long time after they've had their acute or their diagnosed treatment for cancer, but with the backup support and expertise of the cancer care of their non-GP specialist team. The pandemic really has underpinned their value and development. Patients not being able to travel, not wanting to go into a hospital, infection control aspects, reserving hospital capacity and telehealth. But importantly, I think they will actually be needed to address the ongoing burden of cancer care moving forward. And as we move forward, we've got the opportunity to develop and fund these and actually embed them as a cross-sector model of care and support GPs in their provision. And that's certainly really been enabled also by some of the pool funding aspects that have been signalled by the National Healthcare Agreement, and also issues that have been raised in the Productivity Commission reports as well. So that's it from me. Thank you. So now, what I'd like to do is actually invite the panel back and also raise, if you guys could just insert in the question and answer any questions that I might be able to raise. So I might just start off with a few comments. There were just a few comments really to start off with about the telehealth items. A few of the GPs were saying that a number of those they felt were actually for mental health and wellbeing. So it's interesting, so that it would be good to get a more granular aspect about what might be for symptoms of cancer. Is there any way that we might be able to get that data?
Yeah, I'm happy to start that. I mean, I think it's a very good point that while we saw this sort of total increase in GP consultations, we can't tell from the MBS data exactly what the reasons for those consultations were. And that's why we do need better access to other clinical GP data. It's something that we'll be looking at Melbourne University with some more richer clinical GP data that we have access to. That's certainly an important question to understand whether there was a reduction in people presenting with symptoms of cancer in general practice as part of the story. Because all we can see is that there wasn't this sort of expected overall reduction in GP consultations, which is what people had predicted. But what we don't really know is what the content of those consultations were, and it's interesting to see a number of the people put up in the Q&A that they feel that a lot of that increase is actually around mental health, which is not at all surprising. And that we may still actually there'll be a lot of people who are not presenting with physical symptoms.
There was also a comment in the chat box saying that, you know, if people was a comment saying that if there is a new physical symptom, they felt that there was a face-to-face requirement for care in that issue. And I think that you know, how telehealth is being used appropriately is a really nuanced issue that we might develop over time. There's an interesting question here from an anonymous person about fecal occult blood testing. It's easier actually at the moment because people are home because of COVID lockdown. Could cervical screening be improved with a push for self-collection of samples?
Yeah, that's an interesting one. The data around what's the impact has been on cancer screening participation, certainly that there hasn't been any impact on FOBT screening, which is good to see. It's a bit harder to interpret what's happening within the cervical screening program because of this switch from a 2-yearly program to a 5-yearly program. But some unpublished data I've seen is that there has been a reduction in the number of cervical screening tests occurring in primary care. I think whether or not self-sampling is an alternative option to that is a really interesting point. Of course, at the moment, that still has to be done at the GP surgery, though,
Yes.
in the current model.
And that change from 2 years to 5 years has made it difficult to ascertain. But I think that there's also some evidence that there's less diagnostic diagnosis happening after a high screening result. Carolyn E asked an interesting question. How much of the drop-off in diagnosis happened as a result of lockdown, and how much is due to the pandemic overall? Comparing Victorian data with other states. So how much is due to the lockdown and how much is due to the pandemic? I don't think we know that answer. Does anyone
Sue, have you
want to
seen
proffer
other
something?
state data?
Well, I have heard other states have recovered a lot quicker, as you sort of would have seen from some of the screenshots that I showed. We're not seeing the recovery happening in many cancer streams, whereas, I mean, other states, they have definitely seen a rebound. So I suspect that's a result of the lockdown more than the pandemic.
It's interesting. So a question for Jane and Sue, which is, and I found this as well, that GP specialists are easier to get into because they're not doing as much operative work and they're quieter. Just if you have any comments about that, we felt that as GPs.
Look, I think it depends on the specialist. And I think the other thing about surgical specialties in particular, and there's probably a contrast here with medical oncology, is that much of the work we do, we need to actually see patients face to face. So most of our telehealth and video health has been with patients who are either getting results and they're happy to have them with video or telephone, or they've actually got benign results, or they're very long-term follow-up. So for us, life has been more normal than it has for a lot of other people, I think.
So does that mean, has the differences in telehealth very specialist dependent, I presume, is it? Do you know, John? Like some non-GP specialists would be doing still lots of face-to-face work, presumably, those that need to lay hands on, whereas presumably physicians would be doing lots that are still...
Yeah, there is some data in that Cancer Australia report which suggests that that it will vary a fair bit by discipline as to how much telehealth has been adopted. But I think it's interesting what you're saying, Jane, particularly, you know, the follow-up patients, you can sort of clearly see how you could do telehealth consultations, but newly presenting patients, you know, they have to be seen physically, don't they?
Absolutely. I think the other thing is, don't think that we necessarily coordinate well between has the GP seen the patient face to face and has the specialist seen the patient, because we could share our skills. And I think patients are often disadvantaged if they have a run of video or phone consultations and nobody actually sees how they are.
What's been the impact of pathology and radiology in this, and access to pathology and radiology?
I've certainly seen data to show that there's been a significant reduction in pathology and radiology tests being completed. I think one of the bit of unknown is actually whether that fewer tests are being ordered and patients are just not wanting to go and get the tests done, or whether or not you know, the impact of telehealth means that fewer tests are being ordered. I suspect there's a bit of both, but there may well be a lot of concern that patients don't want to go and get their blood taken. But it would be, again, interesting to see what other GPs feel around their experience around that.
We're not seeing any change in the time it takes for the pathologists to do the tests and provide the results back to us. We were interested to see whether that had changed, just because staff may have been redeployed within pathology services to deal with COVID tests and things, but we certainly haven't seen any change in that time delay.
I'm interested to see if the GPs have found a different receptiveness from imaging services, whether they've had trouble with getting certain imaging performed. Not sure if anyone wants to reply to that. There's a comment here that procedural screening is also reduced because of reduced elective lists and COVID protocols with anaesthetic aerosol risk. So, you know, it's very pervasive.
There's been a lot of fluctuation within the hospitals about access to theatre and the level of COVID precautions that have been undertaken. So there have been intervals when everyone's been tested or treated as though they're positive, and that leads to trying to reduce the aerosol and long gaps between cases and reduce theatre throughput. That's essentially over at this point, and so, but not all theatre suites are back to anything like their normal activity.
So I think that this is a really important issue, which is, did many patients have to put their cancer treatment on hold due to lockdown? And if so, how was that prioritised?
I think that at the very beginning, back in March, when I think everybody was really very alarmed at the risk of the health system being overrun and the risk of having immunocompromised patients in the hospitals. There were some patients who had their chemotherapy foreshortened, and there were some patients who had, and I think this was actually to their benefit, inpatient treatments converted to treatments that they could have at home. So, subcutaneous injection rather than intravenous injection. But really, certainly since May, I think people have been having very much standard treatment. And the concern has largely been around not the access of a patient presenting today to treatment, but how we're actually going to manage the influx of patients when people are actually finally diagnosed.
Yes. So I think we're back over to you, John. Is that the case? Just before I hand back over to you, I just wanted to specifically thank Kylie Smith, who has organised us all and very much sorted out my slides as well. So thank you very much, Kylie, and back to you, John.
Thank you, Ines. So just to wrap up, I think this has been a really interesting discussion, and we obviously still have a long way to go to really understand the longer term impacts that COVID has had on cancer diagnosis. There's clearly an important role that GPs play in trying to limit that impact now and into the future. I'd like to thank all our speakers. I'd like to thank again Kylie and Mary from VCCC and the team Linda and Jenna at RACG for organising this webinar. Thank you for all the questions and for people's attendance, and I wish you all well. Thank you.